Okay, so it's 10 a.m. and I'd like to say hello, good morning, and welcome everybody to our Coalition Conversations brought to you by Mental Health Reform. So our attendees will be coming in slowly but surely, but I just want to welcome you and thank you for your time. Due to our technical difficulties the other week, I do appreciate the be able to attend today. So for our hosts, we can speak with them later, but ultimately, I want to give you an opportunity to figure out why coalition conversations is so important. Coalition conversations is an opportunity for us to meet um, through an online facility, like every couple of months, to discuss the policies that shape us and how we can shape them. It's an opportunity to meet, share experiences, and really respond to what's happening in Ireland today. Today, we're looking at a topic that is complex and evolving. It's the HSE restructuring of the 6 health regions in Ireland. And what exactly does that mean for the health services? We recently ran a short survey, and thank you everybody to those who responded. And it brought up some interesting insights. We were able to see that there is cautious hope, but concern. Less than half of our respondents were comfortable with the familiarity of the changes, while some see potential for collaboration and integration of access. There was also several red flags raised about a lack of transparency, maybe poor communication, and the risk that the service users may ultimately be sidelined. So these are very real fears. I think it's understandable when we don't have a clear map, people can feel lost. But we're here today to shine a light on these changes and these concerns and exploring what a meaningful reform should look like from a rights-based, community-focused perspective. So that is the aim of our event today, and I'm going to show for our format. So a little bit of housekeeping. This event is being recorded, which means that you'll be able to access it at any time through our mental health reform website. The presentation will begin with an introduction from Philip Watt, who is our interim CEO here at Mental Health Reform, and he's going to set the scene with an overview of where we are, where we were before, and where we're heading. And then this will open up to a panel discussion where we'll be able to hear reflections from Suzanne Connolly, the CEO of Barnardo's Ireland, and Elaine Teague, who is the CEO of the Disability Federation of Ireland, both bringing phenomenal experience in the community and voluntary sector. And then at the end, to conclude the last 15 minutes, there will be an open question and answer session. So throughout the session today, the webinar, I would invite you to use the question function in Zoom. It looks like a Q&A button, and post your comments there, and we will take them then to the panel at the end. So please, like, this is an opportunity to use your voice for your concerns and to really feel that engagement as we move through this together. So with that, I invite you to grab your notebook, maybe a cup of tea, and then we can get chatting. Okay. Philip, are you there? I'm going to
Yeah.
introduce your presentation now.
Yeah, thanks, Steve, and good morning, everybody, and bright summer's day again. Yeah, the restructuring of our health services is probably the most important development, certainly since the establishment of the HSE in 2005. It has the potential to make a real difference about how mental health and other services are organised and delivered in Ireland. And although it hasn't kept to its original, very ambitious timescale, the pace of change has been significant. So we in MHR strongly support the present reforms, but it's also important to say that the voluntary and community sector has an important role in making the reforms as effective as possible and to contribute to the discussion about how the reform looks. So today is not a day of bombarding you with complicated charts to provide an opportunity to learn more about healthcare restructuring. And I'm delighted to be joined by Suzanne and Elaine for part of the discussion. So I think, first of all, really, it's really important to look at the three key themes of restructuring. People tend to focus in on number one, which is basically the development of the 6 new health regions, which is called the regionalisation process. But it's only one of three key processes. And number two there is about the devolution of decision making. So instead of what previously happened, where the HSE directorate in the centre made all the decisions in a quite a top-down way and told everybody what to be doing, including the regions. There's now been a devolution of decision making to the regional executive officers and their teams. So they are the 6 kind of czars who are over each of the 6 regions. And instead of the centre making the decisions, it will be those 6 people will be largely in charge of our health services once everything has been commenced. And the third key process, which is only beginning to happen now, is the commitment to integrate services, including hospitals, primary care, disability, mental health, etc. So we'll look at some of those issues in detail now. Next slide. So this is basically what's happening from a regionalisation process, which you'd probably be most familiar with. You can see that there are now 6 health regions, and those are the regional executive officers. For example, Tony Canavan in West and Northwest, Martina Quealy in Dublin and Southeast. And you can see how they are all divided. The most complex region is really the East, and particularly Dublin, which is divided between 3 regions, which will be a challenge in itself to make sure that it works. Thanks, Steve. So then again, just to remind you that the previous system was divided into community health organisations and hospital groups. And there were 9 community health organisations and 7 hospital groups. And you can see the areas there in which those groups operated and how they've now been transformed into the 6 new health regions. Some people call them, regional health authorities, but the term, which is, in fact, that's what the term the HSE started off with in this process, but they are technically known as health regions. So it's just sometimes confusing that that term is still being used. Okay, next. So it's important to recognise that we're still in a transition phase. The process is not being completed, and there's a lot of reorganisation. You can imagine a reorganisation of staff and, the regions, the 6 regions from the very complicated system we had before. And each region will have significant autonomy on how their budgets are spent. And this will be informed by a population-based resource allocation system, which I'll talk about in a minute. So you see, these are some of the updates which you should be most familiar with at the minute. And there's a lot of information on the HSE website on this, but again, we are going to be publishing a summary, so you don't have to take notes and don't have to go to the websites. So the key issues are, first of all, that there's the focus of the REOs and the HSE is on integration of services at the IHA level. That's the second step below the regions themselves. And there are 20 IHA areas. So the focus is now on how services, including mental health services, will be integrated at IHA level. As part of that process, there'll be wider discussion with public authorities, such as local authorities, and an integrated service delivery model is being developed. That's called an ISD. And the REOs, the regional executive officers, 6 of them, are presently focused on how the integrated service delivery model will operate at IHA level. So regionalisation is only the first step towards the integration of services. Service and grant agreements, I won't say too much about. There's been a huge amount on the webinars and just to welcome the amount of information the HSE has provided. And most people who are funded through Section 38 or 39 have now returned their grant agreements, and hopefully bureaucracy around that particular process. And was also welcome the fact that, you know, for national organisations, they'll have one point of contact, so they won't have to develop 20 different grants. Very strongly about. The third thing really to watch out for is, and it's at a relatively early stage, but each health region will have a regional forum, and that's going to be for community and voluntary groups. Now, it's important that people recognise that it's not everybody is going to get on this. It's only 17 to 19 people are going to be involved. And it's really important, of course, that mental health organisations are represented on the regional forums, but they really operate at a strategic level. So what I think you really need is people with strategic thinking within a particular region to be part of that. So you want people who are really in the kind of social policy, really is really, really going to be important, rather than trying to compete for places on the regional forum itself. And of course, it's important that the regional forums are accountable as well. Other new development is going to be around patient councils. So these, again, at a relatively early stage, but there'll be 6 patient councils. And from my understanding, this will be more of people with lived experience, whether it be with mental health issues or disability, and so that their voice is, you know, clear to the REOs, the regional executive officers and their teams. The population-based resource allocation is a new method by which funding will be allocated to each health region, and it's quite complex, and it's probably going to be one of the most challenging aspects of the restructuring process. So each region will be increasingly allocated money on a range of issues, including issues like population, level of disadvantage, and so on. So key questions that we have been asking of the HSE is, you know, will each health region have sufficient funding to sustain the services they have at the minute, and indeed to improve services as well? How will the voluntary and community sector fare if the REOs are under pressure to, for example, to fund historic deficits in hospitals? You know, many of the voluntary hospitals are millions and millions in debt. You know, so that's a massive challenge for the central budget. But obviously, we don't want the voluntary and community sector to be the kind of at the bottom of the food chain, if you like. You know, that it's really important that we're seen from a sense of equality. So that's going to be a process, and then we know that the HSE and the Department of Health know it's a particular challenge to try and understand how the best way to do population-based resource allocation. And basically, the system that they're looking at is it seems to be very much shaped by the New Zealand system. Interestingly, in those 2 countries, they're actually rolling back a bit from population-based resource allocation. They see that it may not be the best way to actually ensure that there is equality for each region. And then the final kind of update, and something that people should be looking at, is networks of care, including there'll be a network of care for disability and for mental health, which is really to be welcome. But I think there's still more thinking to be done about what those networks of care are going to be like, and it's still in an early stage. For example, how do they relate to things like the national clinical programs? How do they relate to the community healthcare areas? Is going to be a challenge. We don't want to have kind of a myriad of structures repeating each other. So some further thinking has to be done, is my sense, around networks of care. Thanks, Steve. Next. So just to remind you how the health service will be organised in each sector. And so at the HSE Centre, or the HSE Core, sometimes it's referred to, and that's one of the issues. Actually, sometimes the terms are interchangeable. But instead of dictating to everybody else about how this services are going to be run and what decisions are going to be made, there's a completely new role for the HSC Centre, and their primary focus will be on PEPA. So not Peppa the pig, people wouldn't understand, but Peppa planning, enablement, performance, and assurance. So that's planning, enablement, performance, and assurance. So that'd be a completely different rule from the previous system, where the HS Centre made all the decisions and was very top down, and there was very limited powers in the community healthcare regions that preceded this restructuring. So the health regions, as I stated before, will now be in charge of implementing health policy. So the six REOs will be the people who will be making the key decisions going forward. But I've mentioned before, these changes are we're in a transition phase, and it's likely another few months in which all these changes will take place. Dates. I saw a request there because that's likely to change, but there's certainly another few months before. Yes, and as I mentioned before, there's if you go down to the green area, which is the health regions, there's 6 health regions. If you go down to the blue area, there's 20 integrated healthcare areas, populations of between 150 and 450,000. And below that, there's 96 community healthcare networks, and that includes community services and hospitals. So I want to give you a wee bit of a background. Restructuring is not new. So the next slide there, Steve. So basically, there has been 4 phases of restructuring at a regional level. And the first of those occurred in 1970 with the establishment of health boards, which then became known as regional health boards. They replaced a county system. So before 1970, all healthcare services was structured on a county level, at 26 different regions, and that was a bit of a disaster by 1970 because there was very little focused on strategic and national health interests. So that system creaked along until 2004, in which case in 2005, January 2005, the Health Service Executive was established in its first kind of form. And it was established with 4 regions, but the 4 regions were pretty meaningless, really. It was a very, very centralized process, which we'll see in a minute. Then there's 2013 to 2024. There was the CHOs and the hospital groups, which were preceded the health regions. So just look at a next slide there, Steve. And again, this will be in the paper we'll be circulating. So believe it or not, the health boards had their own boards and were by and large autonomous and were dominated by local councillors. So that was okay from a local perspective, but it was pretty disastrous from a national perspective. And we had a legacy of having far too many kind of hospitals which were not providing specialised care, which took decades to undo. So that was not a good system. It was better than the system that predated, but it was not a good system. Episode 2 was 2005 to 2013 when the HSE commenced. But it was quickly became very criticised as being very centralised, top-down in decision-making in its operation. And the 4 HSE regions had very few powers. So episode 3 was a way of trying to respond to those criticisms. And, we had the CHOs and the hospital groups, but unbelievably, looking back, there was one report sort of suggested the CHOs, and then another report suggested the hospital groups. and there was no integration between the two. So, very unsurprisingly, so we still had a very top-down and centralized system, despite the ambition to have a more decentralized and devolved system. So the episode four, which commenced really 2024, but really commenced from Sláintecare from 2019 onwards, but was slowed down by COVID, was the development of the health regions and the, as I mentioned, the devolution of powers from the HSE centre to the health regions, and also the ambition to integrate services, which are all very laudable and really good ambitions. So it's a significantly different system than before, but trying to avoid the mistakes of the past. So in principle, a lot of what is being proposed is really, really positive. But the wider environment is really key. I mean, a lot of focus has been on restructuring, but as we know, restructuring won't solve some of the issues which are listed here in this. So there remains many gaps and weaknesses in mental health services that integration won't resolve on its own. You can't integrate services when there is no service, is basically the bottom line. So we know there are gaps and weaknesses in mental health services across the country, whether from the milder side of things to the more acute services such as CAMS. There are still gaps there, so extra resources is needed to fill those gaps. Underneath there, the under-resourcing of the voluntary and community sector mental health work providers, which we know about, and fair play to all the work of Save Our Services, which both Elaine and Suzanne and myself are involved in trying to advocate for better funding for the sector. And of course, there's a lack of multi-annual funding, which makes it really, really difficult to plan. And there's no give yet from the HSE on the multi-annual funding issue. Also, the consistency between each health region is kind of a challenge. So there needs to be guidance from the HSE centre to ensure that there's a consistency of approach between each health region, and where each REO and their team doesn't go off and do their own thing. Example, a good one would be guidance for the new regional forums. It's important that there's consistency between one region and another and how the regional forums are going to be structured. A further concern is we've seen some privatisation of services or the commission of services at below cost, which is a matter of concern. So you have organizations trying to compete against each other to provide services, and then realizing that they can't provide services at the level that they have proposed. And we've seen some recent disastrous examples of that in terms of homelessness. So really that's an issue that has to be addressed. The poor standards of some buildings where mental health services and disability services are delivered is really a matter of concern, and it's been flagged by the government. And of course, the importance of making sure that the regional restructuring is integrated with mental health strategies such as sharing the vision and connecting for life, the research strategy in mental health bill, and of course disability services as well. It's really important, and we know that is very much on the agenda of those involved for example, in sharing the vision. So it's the next one. So just to summarize, going towards the end of my presentation here, some of the challenges and opportunities for the voluntary and community sector. But first of all, I think it's to welcome there is a new emphasis on partnership by the HSE, which I have never seen before. I mean, I've been involved in the voluntary and community sector for a long time, and I think it's really to be welcomed that there is time has been set aside to build partnership, and that's very much has been the ambition of the voluntary and community sector. We've been calling for such partnership through the dialogue for voluntaries process and other initiatives. Second down there is a need for yourselves to get to know who your IHA manager is. and their teams and the RAOs, and I'm sure you're all doing that. And but not bombarding people, but looking for opportunities, and certainly one of the opportunities is each region has to organise a conference with the voluntary and community sector every year. So that's a really good opportunity for people to interact. The forthcoming, 6 voluntary forums, but again, to try and think in a strategic way about how that's be involved rather than a scramble to get on them, which wouldn't be helpful. It's like how do we, nominate people who are of ability, but also reflect the different, hospitals, the disability sector, the mental health sector, but also, looking at diversity as well, and we know about the challenges, additional challenges for groups such as travellers, for those looking for leave for remain and asylum seekers and so on. And then in terms of, how there is, links between that and the patient councils, where again lived experience will be key, and there is increasing focus to make sure that people lived experience inform policy, so I think these patient councils will be good, but there needs to be linkages with the voluntary forums. And of course, the voluntary groups have a very important role in terms of supporting people with lived experience so they don't feel that they're on their own. The annual conference I mentioned, challenges arising from the population-based resource allocation is keep your eye on that, because when it comes down to when the HSE decides into each region, the voluntary and community sector just need to watch that we're not at the bottom of the pile. I know from a lot of REOs that that's not their intention, that they see the partnership with the voluntary community sector is important, but they're snowed under, and there's huge resources demands on them, and the wider environment issues, which I've kind of mentioned above. So just the next slide. So just to finish with a couple of quotes. One is from Dr. Sean Lucy in UCC, who said, striking a balance between centralised control and capacity to respond to local needs has long been central to debates about the health system. More regional and devolved health powers are seen to allow greater integration of health services and enhance democratic and community participation in policy. However, critics argue that increased localism lessens central government's responsibility and perpetuates inequity in funding services and population health. And then also a woman called Anna Quigley, who did a really good report for the Health Research Board. It's well worth looking at. It's looking at regionalisation around in 6 or 7 different countries. And Anna concludes, regionalisation is a complex process for which outcomes are neither straightforward nor predictable, but dependent on its country's socio-economic, institutional and cultural contexts. The impact of regionalisation will not be fully estimable for many years post-reform. However, a monitoring and evaluation process will be required at the start of the process to ensure the short-term goals and immediate goals are met in order to achieve long-term goals of regionalisation. And I would also add to that we need to look at how regionalisation and integration of services and devolution of powers is working its way out in other countries like New Zealand, and there's already been changes since the Irish government based their system on other countries, or just help them form our system. So thank you very much. I hope that's okay. I didn't bombard you with loads and loads of charts, and I very much welcome to the discussion. I'll hand you back to Steve now. Thank you.
Thank you so much, Philip. Thank you. Really appreciate that and the time and the effort it takes to try and put shape on something that could seem very nebulous. And for those who are interested, Philip's presentation, along with other information booklets that we've purposely designed for you, are available on our Coalition Conversations portal. And during the session, I will post the link to that into the chat function. And now, for this portion, we're going to hand it over to my colleague, Roisin, who's going to introduce Suzanne Connolly, CEO of Bernardo's Ireland, and Elaine Teague from CEO of Disability Federation of Ireland, and to include Philip as well, not forgetting Philip, to listen to their viewpoints and how it affects their own respective fields. Okay, so I'll pass it over. Thanks very much.
Thanks so much, Steve, and thanks so much to the panelists for coming. Really appreciate your input on this. People are welcome to add questions to the Q&A function here, but we do have some questions kind of prepared, gathered ahead of time as well, so we might start with some of those. So just one there for Suzanne Connolly, who's with Bernardo's. Suzanne, how do you envision this restructuring, reshaping the support ecosystem for children and families, looking specifically at families with kind of already more complex needs?
Well, maybe before I look at that question, I just want firstly like to say well done to Philip for a very comprehensive outline of what's something inherently very, very complex. And I look forward to both getting the presentation and also the papers. And I suppose what I was really struck by as I was listening to you, Philip, was to think about like what would an effective region look like from the perspective of the service users, so across the range of needs that people have. So if they were to say to us that it had delivered better services and the outcomes were being achieved, what would that mean for how it was actually being established? So I think that's the key question that by which we can evaluate the success of this. And I'm struck by the quotes that you shared at the end. And absolutely that quote about implementation takes time. It does. It takes 5 to 10 years. Now that's not very politically popular, but that's the reality. If you're really trying to make a difference in terms of the whole systems change and systems approach. I think one of the things that struck me in the context of the point about the ecosystem is that, and I'll talk particularly from the perspective of children and families in the context of mental health. So I know Elaine will be talking about disability, but I think one of the things I would say is that what you need is you need a range of services from prevention or intervention to the acute level of need. And one of the things that will have to be established as part of this approach, which Philip, you actually did touch on, was that there will be a need both for things that can be generalised at that local regional level, but there will also need to be specialisms, which may need to be national by virtue of the expertise that is needed, but also by virtue of the cost. So you couldn't have, six different, I would argue from a financial point of view, you can't have particular specialist services at each region. I don't see how that would be possible in the context of the budget that's available. I think what's interesting to think about when we look at what's achieved a lot of attention, I suppose, from a children's point of view, is CAMHS waiting lists, and to the extent to which the system is completely overwhelmed in the context of the needs that's there. And in order to provide effective services, and I know the mental health reform has done really good work in this context, you need really to intervene at an earlier stage. And this is where the community and voluntary sector really comes into its own in order to reduce the likelihood of children and young people ending up on the CAMHS waiting list. And also you need to ensure the children who need that degree of specialism actually get the services that they require. And I know that the Children and Youth Mental Health Office is very much within this way of thinking. So that's also important. Like when we talk about, how we influence the success of this ambition, we need to be listening, as you highlighted, Philip, to the people who can really help strategically in that thinking. While at the same time, I would say is that we don't forget about the importance of attention to implementation and what that means and the reality of what that means. And I think it would be remiss not to recognise that all of this is achieved through people. And we know that the pressure that's on the HSE system to retain people in roles, and this will not be successful unless key people from a leadership point of view can stay within the roles. So that's going to be really important. So no matter how good a plan is, if we don't have consistency of individuals within it, it won't be achieved. I think it was interesting what you were saying about we all know data collection is key, and population. In some ways, population approach is very interesting because we know that there's been inherent, if you like, unfairness in the system. Some regions have got a lot more than others, and this is across the by virtue of political lobbying, for want of a better way of describing it, and other things. But at the same time, I suppose, how do you allow within the demographic approach for then potentially the sharing of the redistribution of resources. You know, so if for some reason one area requires less by virtue of demographic changes, how can you facilitate the change elsewhere? And that, I think, is a question that I don't know how we could resolve, because it's very hard for people to give up stuff once they've received it. And there's always a degree of unmet need. And that's the other thing I think what probably is not given sufficient attention, because it's such a complex subject, though I know in mental health reform we're very much aware of it, is how do you manage for very relevant competing demands? That is the trick. I mean, how do you manage that, and how do you recognize that in making choices you will not keep everybody happy, you know? And that's, I suppose, something that the people who do a lot of thinking in this area know that that's the case. So you can spend, if you think about it in the context of what gets attention, the individual child gets a massive amount of attention because a story, you really resonate with the story. But sometimes by virtue of that, it means that by meeting the needs of the individual child, and this might be quite a provocative thing to say, but it's true, then as a number of other children who may not have an acute level of need, but still have a need, their needs will not be met. And they're the tough choices that we actually have to make. And I'm seeing this as a safe space, if you like to say this, but I think that's the reality. The other thing, I suppose, that's quite close to our heart in Bernardo's, and I know that's shared with others, is the health system tends to be quite individualized in its understanding of an issue and need. And we would say sometimes what's needed from our point of view is both a whole family perspective. So a child and young person's mental health may really be very much impinged by what's happening within the family or within the broader context in which they're living, like poor housing, or they can't get a school place, or then other services aren't available. And that if you really want to address that need, you need to take that holistic approach. And that's where I really like the idea of networks of care, because the networks of care may really facilitate an understanding of that in fact what this child does not need is to see yet another psychologist. What's actually needed is support for their parents, or they need a house. You know, they need a proper accommodation in a house, which would then really improve their needs, or they need a school place, you know, whatever that might be. And then I suppose the other point, maybe just to maybe, you know, finish with, because I'm interested in hearing from Elaine. I'm also interested in hearing from the people who are listening, and indeed from their questions, is how do we, from a funding point of view, ensure that there's it might be even shared commissioning across the different government tranches of money. So, for example, from a Bernardo's point of view, there would be a lot of the children we work with would have contact with TUSLA. We're commissioned by TUSLA. We have less commissioning from the HSE, yet sometimes we're talking with the same group of children. And I know when Elaine comes in to talk, the children with disability there'll be children with disability who are in the care of TUSLA, who have particular needs, and this whole issue what happens after 18 for those children. So I think the more they're joined up thinking there can be at government level, I think the better, and ideally joint commissioning. And I suppose my last point really is, surprise, surprise, is about funding and the economic reality of the community and voluntary sector, which I know people listening will really share, because my worry is, given the potential of a downturn in the economy, that notwithstanding what you said, Philip, about the people you've spoken to be very supportive of the community voluntary sector and its contribution, that it may look to cut the budgets of the sector, and that would be so regressive given the contribution that is made and the key importance, I suppose, of the sector to delivering across all the different care pathways, for whatever client group it is. So I think that's really important. And I think we have to work very hard, not just with our colleagues in the HSE, but with deeper and the departments for that to be recognised. But I do think, Save Our Services is doing that. I know, Philip, that the Mental Health Fund does a lot of that. So I just think we really need to continue that, because I think what tends to happen with the sector is there's a real recognition and there's real praise given to what the sector contributes, but it's not sufficiently recognised, I suppose, in paying for the actual cost that it takes to deliver effective services. So thanks very much.
Thanks, Suzanne. That's a really well-made point. And it would be great to hear from Elaine Teague from Disability Federation Ireland, just because I think what you're speaking about applies to so many aspects of healthcare. So welcome, Elaine, and her comments also.
Thank you. Really great to be here, and thanks Philip and Mental Health Reform for putting together, this very complex situation in terms of the change in the HSE. But for us in disability, there's also additional complexity that I might just mention. So I don't know what the stats are like in mental health reform or in children's, but in disability, 70% of disability services are provided by the community and voluntary sector. So we are part of this ecosystem, and we need to be understood and engaged with as a critical part of this ecosystem. If we're not engaged with at a very early stage, 70% of disability services are going to wonder what's happening in this world. They're going to wonder, where do I fit? Who do I talk to? So we are a significant kind of important stakeholder. And my experience so far, having met 4 of the REOs, is that they're all very dedicated, very committed, very engaged individuals who have limited experience in disability services. I think they all have a lot of experience in acute settings. They've a lot of experience in counting trolley numbers, in counting the number of admissions and discharges, managing wait lists for surgery and all of that really important stuff. But I would say limited enough in their knowledge of social care, limited enough in thinking about people living good lives. And just to pick up on Suzanne's point, it could be about a new house. It could be about a school place. It could be about transport. It's not necessarily about what would fit in the typical health kind of box, if you like. So in disability services, I think we're also struggling a little bit with, we have a new strategy which has just been finalized. And that's called the Human Rights Strategy for Disabled People. The REOs haven't really had sight of that, so they haven't been able to influence that. So they have maybe limited understanding of their requirements in terms of their workload to deliver on a human rights strategy. We also have a programme for government, and there's 71 disability measures in a programme for government. And there's talk of a whole of government approach, but really we've seen little evidence that that has actually translated into action just yet. So we'll hold that with a little bit of optimism that it might come. And we also have public sector reform. As Suzanne mentioned, we've got to engage with deeper. We've got to be able to produce our data. We've got to be able to demonstrate accountability and all of those kind of really important buzzwords. And for us in disability, Suzanne referenced CAMS wait lists, and in disability, we all know that it's assessment of need, the dreaded AON and the wait lists for that. So this HSE restructuring is happening within that context of all of those other changes and all of those other demands. And that's really very significant for us to try and keep up with that. So I think the more of this kind of event we can do, where people share experiences, share what's worked well, share where there have been challenges, that we'll all perhaps feel a little bit more empowered to engage with this significant change. And I think, look, the ambition for this change is that people will have access to the right care at the right time in the right place. So let's hold that as what we talk about when we're talking to our HSE colleagues. Well, how is that going to help me get the right care at the right time in the right place? How is this restructuring going to make sure that the people that we support have access to the right care? It's not just about the bureaucratic shift of responsibility, but it is ultimately about people having better services. So I think it's important that we kind of understand that there are lots of changes happening, and the 6 REOs have their teams that are being established, and I think they're managing their communications internally reasonably well. But what's for me the challenge is that they often march off down the road and forget to engage with their community and voluntary partners, forget that we're actually going to be the ones that deliver these services. So I look forward to trying to help them understand the importance of communication at a very early stage. And I don't know what it's like in mental health or in children's, but in disability, the grapevine is the fastest working communication network ever. And so people hear some information, it gets translated and understood through organizations and all over the place. And before you know it, information has been incorrectly shared because it wasn't the correct information. So I'm all the time saying to REOs, even if the update is there is no update, that is better for you to say that than to say nothing, because when you say nothing, that leaves a space for people to interpret or to understand things in a different way. So I'll just maybe touch a little bit on some of the potential benefits that I think for disability services we see. We have been advocating for a long time for patient and service user forums, the lived experience forum, as you described it, Philip. And now I do see a real commitment to that. I see that there's a real commitment to doing that and to doing that well. It is taking a bit more time than we would like, but it is good to think that this structure is not an optional added extra. It is a requirement that everybody will have a patient and every region will have a patient and service user forum. And I think it's up to us to make sure that we have people with lived experience who are ready to step into that place, who feel supported to step in and ask the questions, who have opportunities to maybe meet with our members so that they can hear directly from people and represent the patient and service user voice at those meetings. Like you said, Philip, I think the partnership principles are in place, and I think we can both sides of the coin can hold each other to account on partnership principles. So I find myself saying to my HSE colleagues, well, in line with partnership now, what this would look like is, and I find them saying back, that's fine, Elaine, but we need you to do that. So we can have this kind of more honest conversation now that allows those conversations that have been challenging around funding, multi-annual funding, wait lists, prioritization. I think we can have that now in a way that is a little bit more, it's a better, safer space to have those conversations. I like the idea of this being population-based because it allows for tailored needs in each region to be considered. If you've got one region who have a particular high density of something, of a particular challenge, then they should focus on addressing that. So I think it allows a kind of the regional flavour to be considered. And I would just like to pick up on your point, Philip, around the voluntary regional fora, and not to compete with each other for a place on that fora, but to figure out how do we represent each other when we're at that fora? How do we hear from each other? How do we make sure that if I'm going, that I'm not just talking about disability services, I'm talking about disability services, and I've checked with Philip and I'm talking about mental health, and I've checked with Suzanne and I'm talking about children and families, so that we join ourselves together so that our joint advocacy is much more effective. We have experienced a divide and conquer approach up to now. People are carved off into, well, your mental health over there and your disability and your children. And now I think we're better at being together in the space and advocating for each other. So I think that's a really important, it's a really important piece of progress that we've made as the community and voluntary sector, is to not allow ourselves to be divided and conquered, but to come together and have those discussions. I do think there are some risks and challenges, and I think we're in response mode. So there's a changing landscape. We're just responding to those changes at the moment, and we have very little time to just be strategic and to think. Like was mentioned, the multi-annual funding is not part of this conversation in terms of the HSE restructuring. Is there enough money to do all that's needed? No, there isn't. Are there decisions to be made? Yes, there are. But it's not yet clear how that's going to happen. So I think there's a bit of thinking about, lots of people say there's things you can do without money, but money matters. People have to have funding to be able to deliver good quality services. I do think there's changing relationships, and there's a risk that people who, you knew yesterday who to pick up the phone to and talk to, and that person has now gone to a different role, and now who do you talk to? Who do you ask those questions of? So there's a risk of that kind of relationship change, and therefore people feeling not confident. And the final risk I would just talk about maybe is just the inconsistency across services. So I'm all for regional flavors. I'm all for regions making decisions and for decision making to be more local, closer to the person. But I think what's not okay is when the flavors become fundamentally different, when you've got one REO who does things in a very different way than somebody else, because then you're back to postcode lottery. You're back to, depending on where you live, you get access to a particular thing or you don't. So I think we have a role, Philip, Suzanne and I and our colleagues in other organisations, to say, actually, that's a step too far in terms of regional flavour, and to come back and have some consistency across those things. I would just maybe for 1 second say, I think everybody on this call has to think for themselves, what does this mean for me, for the services I work in, for the board that I report to? What do we need to pay attention to? What kind of risks does this pose for us? And then you have to get into a conversation with your HSE colleagues to understand those risks from their perspective, and so to start to think about how do we together address those risks. And finally, I would just recommend to everybody thinking about embedding the voices of service users in governance arrangements, because that is the future of this. That is the future of how we make sure that lived experience influences what we do, what we say, how we think. So we have to show some leadership and start that conversation within our own organisations. So for me, they're the kind of the key things that are going on around regionalisation, but it's certainly a complex area.
Thanks so much for that, Elaine. That was a really good kind of overview. Just something that you'd mentioned there about how much money matters for services. We had a question come in asking if we know changes, what changes are happening to Section 39 funding. So if any of the panelists had any kind of knowledge on that or thoughts even.
So I could maybe share our experience of that. So our experience is that there is in 2025 no change to Section 39 funding arrangements. It is business as usual from a disability perspective around funding. There is some mapping to be done in terms of organisations that have a national role and organisations that have a more regional role. Regional organisations, it's very clear, their funding will go to the regions and will be distributed through the regions. National organisations, there's some more thinking to be done. And that's certainly a conversation that Philip, Suzanne and I want to be influencing about how that gets done and how that gets organised. So I think, there isn't a roadmap for change in funding arrangements that I know of, that I haven't been part of any of those conversations. I've no doubt they're happening somewhere, but I'm certainly not at that table. Maybe Suzanne or Philip.
Well, if I can just come in just quickly, just to say, and it's a reference to a point that Philip was making about below cost commissioning that tends to happen in Section 39. And one of the things we're advocating as part of the Save Our Services group, which is made up of a variety of Section 10, Section 36, and Section 39 organisations, to really argue for an increase in the cost of living, a recognition of the cost of living in all the SLAs, because I think the system didn't really understand I'm hoping the system, the funders, the impact of not having even small percentage increases on the community voluntary sector. So that's a very basic thing that we're all out working very well together. And I completely agree just what you're saying there, Elaine, about the importance that we really do work together. We recognise the fact that, like from Bernarda's point of view, assessment of need and the gaps thereof are massive for the children and families with whom we work. So there's real synergy across the variety of service providers. And the more I think that we can show the civil service and the politicians that we do work together, the more we actually will be listened to as a composite group, the better. And contribute to strategic thinking as well in a really important way.
Absolutely, thank you. Just something that I was kind of getting from the discussion was the importance of regional voluntary fundings and the way that they could be run in a way that would be helpful and kind of valuable in terms of getting feedback from the voluntary and community sector. I wonder if anyone had any thoughts on the ways in which those could be well run.
Maybe I'd just come in there. I think it's the forums are going to be really important, but just to re-emphasize the point that I think they need to be really focused on strategic issues, really. The need to work collaboratively is really, really important. And I welcome the HSE are going to develop guidelines for all 6 regions so that one region doesn't go off and do their own thing or set up something which is really, handpicking people for, which is the worst kind of stuff, which has happened in the past a lot. Where the HSE sometimes pick people's for their compliance rather than their robustness or even the awkward voice always has to be listened to is one of my favorite sayings, so yeah, a lot more work has to be done there, but there's a guy in the HSE who's leading up in that process who I think has a real understanding, so fingers crossed. I think it'll be a good process.
Okay.
I love that, Philip. The awkward voice has to be listened to. That's great. That's my phrase for the day.
Yeah, sometimes it's difficult to hear, but sorry, back to Roisin.
Absolutely. So just a general question for anyone who'd like to answer. What advice would you offer to community and voluntary groups who are trying to navigate the emerging governance and funding systems within the new health regions? That's a tricky one.
Well,
Yeah.
it's about relationships, right? So wherever you are, it's about understanding who's your counterpoint in the HSE. Find out who they are, get their number, get their email, make the connections. I would suggest that having conversations about finance is not your first point of contact. So for us, when I go talking to the REOs, I go saying, do you know we do all of this? You know, we're part of your region. We're here to help. We want to contribute. What can we share? Here's our data. So I would suggest that find out who your local counterpart is, make the connection, because when you build those kinds of relationships, then you can pick up the phone when things go wrong. And really what we want to be able to do is work collaboratively. It's not them versus us. It is they have the funding and we have to position ourselves as strong, robust organizations who can and will deliver what they are required to deliver by the Health Act. So they need us and we need them. It's a synergy relationship. So I'd say don't wait if you can. Don't wait for them to find you. Make it a point of going to find out who they are.
Yeah.
Thanks, Emil. Any thoughts from the rest of the panel?
No, I think very well said by Elaine.
Fantastic.
Okay then, well, I think just looking at the clock there, I'd just like to thank Roisin for moderating that section and for the insights posed from all varying different views, but all in the same area. So thank you for your contributions. Do you have any closing remarks?
I'd just like to thank you. Sorry, Philip, I just want to say thank you for organising this. I think it's an excellent format. I really like this just for an hour, and well done to Mental Health.
Thank you very much. It's our pleasure. Thank you. Okay, well then for our audience, I hope you can see me now. Just want to say thank you for your attention and for the questions that you've posted. It's a complex and changing area, and I hope that this brief overview maybe has been able to allay some concerns, and concerns are completely normal. For more in-depth analysis, I would invite you to look at our content that we've prepared on our mental health reform portal. I'm reminding myself now to paste that into the chat function for all attendees. And for anybody who has any questions after the event, please do not hesitate to give us a shout. You can contact me. So that link is there now. So for all our members, allies, supporters, and for our panelists, a big thank you today for your participation. I can put my hand up. This is very complex work. Zoom and also the subject matter at hand, but it's when we work together that's when we can work through it, I really feel. I'd love to bring your attention to some events in our mental health reform calendar coming up. In the next couple of days we will be marking Starry Night, which is our awareness day, just to highlight what exactly we do and the advocacy work. That will be on the 20th of May, so keep an eye on our social medias. We will have a subsequent coalition conversations topic in the coming months on the subject of suicide prevention, so very timely in the media, and will coincide with forthcoming research that we are preparing on the topic. So again, we will be communicating that in the coming weeks. And also, we want to hear your views on mental health across the board. It's pre-budget submission season is coming up, and we want to give you the opportunity to tell us your opinions on mental health and the provision of services in Ireland. So there is a survey that we can ask you to complete. We have a deadline of tomorrow, actually. It's been circulating for a couple of weeks, but there's no harm in just giving a little reminder to you. So again, if you want to look in the chat, that is for you there. So please do use this opportunity to use your voice. Like, we all deserve to be acknowledged. I think they are the calendar items done. So I think with that, I would just like to say until next time, take care of each other and yourself. And yeah, thank you very much for your participation.